Okay, so thank you very much. I would like to thank the organizers for inviting me down under here. That's completely amazing. Just want to share with you how it looks where I come from, so I feel pretty warm. Yes, I was walking the dog recently. It was just fantastic. Right now, I'm getting so excited about being here, so we are considering becoming hobbits. But more than anything, we really want to study to be Kiwis. So we've had an amazing time, and frankly, just to be a little more serious, I think that a whole day on vitamin C is just such a tremendous treat that we rarely get a chance to, so I'm really thrilled to be here. What I'm going to try to talk to you about today is this vitamin C and its rather special pharmacokinetics that I think has impacts both in terms of how we do or should be doing our clinical studies, but certainly also how people have interpreted the studies that have already been conducted. And I think probably a lot of mistakes have been made along the road, and I'd like to draw your attention to that. Then, if time permits, I also received some very fresh data, actually after coming here, so they're very fresh. And if time permits, I'll show you some interesting data from a small pilot study that we made. So, anyway, just to make sure we're on the same page, I'll take you back to first year at med school. I think probably if you need a drug to cross a biological membrane, there are several ways that this can happen. The most common way would be the simple diffusion, where the drug will travel through the lipid bilayer. There are also other means, active transport, for instance, but the key feature of simple diffusion is that you need a concentration gradient, and you need a compound with a certain degree of lipophilicity to be able to cross this membrane barrier. And just to sum up very quickly the typical features of a low molecular weight pharmaceutical drug, you have this linear kinetics that is basically throughout the therapeutic range, and we typically reach these nano to micromolar peak concentrations. Passive diffusion is by far the leading way of distribution throughout the body, and the equilibrium that is reached, in contrast to what we showed just before, that Margrethe showed us, we here have a situation where the PK and the pH, the lipophilicity and protein binding, are the determining factors of how drugs actually distribute in the body and what the ending concentration would be. We have the first order elimination kinetics, I'll show you in a minute, and then we have a relatively fast excretion of these compounds, modified perhaps by phase 1 and phase 2 enzymes for excretion through urine and bile. And that means that we can use our kinetics, our modeling, either the non-compartmental or the compartmental modeling, to mimic how the concentrations change over time. So this is our standard scenario, and let's just have a look at vitamin C. Usually we talk about ADME, obviously, and these are the issues that I see for vitamin C that is different from what you would see for a normal low molecular weight pharmaceutical drug. And basically this list accounts for most of the pharmacokinetics that I teach my students when I come back from here next week. And so it's a whole range of very important issues that has to be taken into account if you want to know what vitamin C concentrations are throughout the body. So first of all, membrane transport, as I mentioned, is extremely important, and the passive diffusion is the means of normal drug distribution. Well, for vitamin C, this is really extremely slow if it occurs at all. It probably occurs, but we don't know much about it. The thing is that vitamin C is extremely water soluble, and at physiological pH, you have 99.99% ionized vitamin C. It means that it has a charge, and it won't be able to cross the lipid bilayer. Now for drugs, that would normally not be a problem, because if only a tiny fraction is unionized, that would be able to drag the compound onto the other side of the membrane. But because of the very high water solubility of vitamin C, it seems that the passive diffusion is extremely low. In the stomach, we, for instance, would have, because of the low pH of the stomach, for instance, we would have 99% unionized vitamin C. So that would make you believe that there might actually be some kind of diffusion there. But it so far has not been shown that it actually ends up getting across the membrane. Then we have the facilitated diffusion, which is also needing a concentration gradient to occur. This is the GLUT transporters, and it's been shown that oxidized vitamin C, as Margrethe mentioned, dehydroascorbic acid, is able to cross the membrane through a glucose transporter. And this happens at a fast pace if the concentration gradient is present. Normally, though, at healthy physiological conditions, there will not be dehydroascorbic acid floating around in the veins. So this transport, again, is believed to account for only a small proportion of the distribution of vitamin C. So we're left with active transport, and two major transporters have been identified. We have a high affinity, low capacity transporter, and we have a high capacity, low affinity transporter. So here we have the, down here we have the one with the high affinity but low capacity, the SVCT2, which is typically responsible for the distribution throughout the body, whereas the epithelial transport from uptake and reuptake in the kidneys will be taken care of by a high capacity transporter, the SVCT1. And this is similar to what you showed us already. And so what I want you to notice is really the large difference in concentrations throughout the body. And also the fact that in contrast to most other compounds you could think of, vitamin C has concentration dependency built in to both its absorption, its reabsorption, and also its retainment in certain organs. For instance, the brain that I've been studying for several years, you see something really remarkable, in particular during deficiency. You will have a situation where the entire body is drained for vitamin C, but the brain remains more or less intact. So we did studies, for instance, in guinea pigs. After 6 months of marginal deficiency, the liver, for instance, would have 1% of vitamin C back or left, while the brain would have retained more than 50% of its original concentration. It's also here you find some of the highest concentrations in the entire body, with neurons containing up to 10 millimolar of vitamin C. That's an enormous concentration of a compound like this. So clearly showing that it's probably extremely important for the brain. And we're now starting to look, in fact, into the bone marrow and some of the cells there. And it seems to be there is also a variety of cells and a variety of concentrations depending on which cells that we are talking about. So this is very interesting. And you can also wonder what the difference is between the organs. Why is there such an enormous difference between concentrations? Because it's not like the passive diffusion we talked about first. It's not determined by passive diffusion differences. The pH is the same, so we would assume that the concentrations would be the same, but they're not. So clearly this is a matter of, to me at least, it's a matter of demand, rather it's than physiological conditions of the particular organ. So this is very interesting. Intestinal absorption of vitamin C is very complex, and we're not going to spend much time on it. And just when it comes into the intestine, we have this intestinal epithelium, and we have the SVCT1 probably being the most important carrier of vitamin C into the epithelium. It's interesting, though, that we don't know how it leaves these cells again. It's been discussed if there were maybe some volume-dependent ion channels, if there were an SVC2 that was turned the way around, so it could basically suck vitamin C into the bloodstream. But as of today, as far as I know, we don't know how it leaves these cells. But obviously, as the bloodstream, as already mentioned, is the major liquid for distributing vitamin C in the body, it's necessary that this process must be extremely efficient. So that's something really a need to know thing as far as I'm concerned. So intracellular buildup, we have the SVCT here, and from plasma or extracellular fluid, you will suck up vitamin C, increase the concentration. If there is dehydroascorbic acid, it will enter through this GLUT transporter and only in the direction of the concentration gradient. DHA is very efficiently recycled inside the cells to ascorbic acid, and again, the diffusion seems to be very low. We can typically have a gradient of about 40 to 1, so it's a considerable build-up against the concentration gradient here, so typically for active transport. Then, if we have challenged conditions, we see either retainment or depletion in the brain, as already mentioned. We have the SVCT2 here that can suck up vitamin C from the surroundings at the expense of the remaining tissue. And here we can get typical gradients of about 500 to 1, again, so extremely efficient take-up through the SVCT2. Then we have the depleted organs. They have a problem because they have a mixture typical of the SVCT1 and 2s. For instance, the liver will very quickly lose its vitamin C, probably ending up with increased oxidation inside the cell, which may actually cause DHA to leave the cell through a buildup of a concentration gradient. So here, maybe we have a gradient of only 5 to 1 compared to the 40 to 1, which would be the normal. So, in the kidneys, normally we would have the glomerular filtration here ending up in the kidneys where we have water resorption, pH lowers in the kidneys. Once you take up some of the water, we get an up concentration of vitamin C and we would get it excreted. But here, vitamin C, again, is very different from any other drug you might see in the sense that we have active reabsorption, which is pretty unique. But again, how it leaves the renal epithelium is not known. This is a relatively iconic paper. I would say some of you may have seen it many times already. This is the Levine study from 1986 that showed the nonlinearity of the vitamin C pharmacokinetics. If you increase the dose here, you see that the steady-state plasma concentration does not just continue to rise. It actually saturates at some point, and you can discuss where it is exactly. Typically, we would say that it's between 70 and 80. Considering the error bars, you would reach some kind of saturation. And mind you that for our normal therapeutic drug, low molecular weight drug, you would have something like this. You would have a linear relationship. Increasing the dose, you would have linear relationship to area under the curve or plasma steady-state concentration. So this is completely different from what we see for normal drugs. I also want you to focus on this particular thing. This is the excretion fraction. For a normal drug, you would have basically a flat line, depending on what drug we're talking about. Here we have a dynamic window suggesting that if you have very poor vitamin C status, you have an excretion fraction of close to 0, which means you don't excrete vitamin C at all. You will reuptake everything that ends up in the kidney. This is an extremely efficient mechanism for retaining vitamin C in the body. under challenge conditions. On the other hand, if you move up here, you get sufficient vitamin C. You are well above 1,000 milligrams per day. You will get very close to 1 in excretion ratio, suggesting that you basically excrete any surplus that you don't need. So this is, again, very special situation for vitamin C compared to other drugs that you may encounter. So here, just to summarize, pharmacokinetics of vitamin C, nonlinear absorption kinetics, and we have these saturable active transporters. We have a distribution based on tissue priority, which is pretty unusual. We have the micromolar plasma concentrations, but millimolar tissue concentrations, which is quite a bit. We have the oxidation in vivo, but also the very efficient regeneration of the vitamin C within the cells, which is also extremely unusual compared to other drugs, and the nonlinear elimination kinetics. So what does that add up to? Well, it adds up to the fact that it doesn't really comply with the basic assumption of either nonlinear, non-compartmental or compartmental kinetics, which suggests that there is what we call a terminal first-order kinetics phase. So that means that a lot of the calculations that have been made in the literature on what is actually the body stores of vitamin C, they're at least in conflict with this fact. And so what that actually means for the calculations of the body stores, we don't know at this point, but it's certainly something to consider, because the body store calculations that were made in the 60s by Kollner and others, they are basically founding the recommendations from the authorities on how much vitamin C we need every day. So this is really important stuff. Oral versus intravenous administration. Well, again, for a normal drug, you would have an IV injection here and an oral administration here. You would basically have a similar half-life of the drugs, signifying the first-order kinetics. So this is some of my data from an old study where we just took people that had sufficient vitamin C and gave them a little more oral, and we measured the change in plasma concentration, and you can see it's almost a flat line. If you had people that were low in vitamin C, you would see something like this, where they basically started down here, and they increased up here, and they would not go down again. So this is very, very different from the kinetics that we see for normal drugs. We did a study in cancer patients. Basically, it was a safety study in terms, and a pharmacokinetic study, where we had 10 prostate cancer patients, and we tried to give them various degrees of IV infusion to monitor the pharmacokinetics of vitamin C. And this is what we found for the various doses here. I hope you can appreciate that these lines are relatively linear and that they are parallel. And what this suggests is that also the calculations suggest that we actually have a constant half-life of vitamin C when you exceed the physiological concentration. This also means that the clearance is the same, and that means that you can predict the plasma concentration using vitamin C in high dose, which is really convenient. It also suggests that vitamin C actually switches from this zero-order kinetics that I've been showing you so far to the first-order kinetics when given in pharmacological doses. So, something that would also be very interesting to talk about, but I don't have time to talk about, this is factors influencing this dose concentration relationship. And I've been working with quite a few of these over the years, and certainly smokers have a lower steady state level of vitamin C compared to non-smokers. We also see interesting new things, developments with genotypes, We have pregnancy and lactation where the child or fetus is actually preferred to the mother in terms of sucking up vitamin C from the pool. And as of today, with our today's topic, we also have obviously acute and chronic disease as a major influencer of the dose-concentration relationship. I don't know how much time I've spent so far, I've lost track. But we have a very important discrepancy in the literature, I think, between epidemiology and randomized control trials. And I've written quite a bit of that, and I'm not going to talk about it today. I'm just going to show you just a few examples of the problems that we are facing here. I mean, randomized control trials obviously is considered the gold standard in testing efficacy of drugs, and so it should be, but they're basically not developed to test essential nutrients for a number of reasons. There's something here about high statistical power in secondary prevention compared to primary prevention, but also, and very importantly, I think, randomized control trials need some kind of control group. And this is extremely difficult when you look at studies with vitamin C, because we all ingest vitamin C daily. A lot of people take supplements, and if you don't take this into consideration, you're basically testing two different doses in a situation with nonlinear kinetics, so you end up having studies that make absolutely no sense. Then you have the healthy enrollee effect, which is also very common in these studies. If you recruit people for a vitamin C study, you will get people that are health conscious, they exercise, they do all the right things, and that means that they usually have a high level of vitamin C. So if you don't specifically try to select people with low vitamin C status, you won't have a chance to see anything. Just to give you an example of how wrong some of this stuff has been done, I'm showing you some of the major randomized control trials within this field. Thousands and thousands of people have been engaged in these studies, and of these 4 major trials with vitamin C, 3 of them allowed the placebo group to continue to take supplements up to the RDA, which for the Americans would be 90 milligrams per day. So on top of your ordinary diet, which would also contain vitamin C, you are allowed to take 90 milligrams per day. So if you can remember my curve on the dose concentration relationship between dose and vitamin C in plasma, you'll see that a lot of these people would already be up in the saturated area. So they won't have any benefit from adding on to this treatment. And even though you have thousands of people here, the chance of seeing a difference is close to zip. So this is really bothering me quite a bit. And I'll end this part just saying that I hope to show you that vitamin C is nonlinear. It's pharmacokinetics at physiological levels and first order, and linear at high dose pharmacological doses, and basically highly different from that of a normal low molecular weight drug. I haven't had much time to go into these details, although I think they're extremely important. Obviously, we have problems with epidemiology in terms of establishing causality, but I want to stress that I feel that the RCTs also have enormous problems within and limitations within this field. And what we really need is to know more about the dose-response relationship between vitamin C and its actual clinical effects in order to determine what the necessary intake is, in particular in sick individuals.